I nuovi farmaci per il diabete sono stati veri protagonisti dell'edizione 2023 del Congresso dell'ESC, il Congresso Europeo di Cardiologia. Accanto agli SGLT2, protagonisti delle linee guida per lo scompenso cardiaco, anche i GLP-1 agonisti, in particolare la semaglutide, ha dato dei risultati molto incoraggianti, molto promettenti nei pazienti con scompenso cardiaco e frazione di eiezione preservata nello studio STEP-HFpEF, in cui è stata impiegata il dosaggio di una volta alla settimana. Noi ne parliamo col principal investigator dello studio, col professor Mikhail Kosiborod. Professor Kosiborod, first of all, which were the patients enrolled in the study? Which disease and which were the situation?
Right, so in the STEP-HFpEF trial, the key objective was to determine whether the patients that have heart failure with preserved ejection fraction and obesity would benefit from treatment with semaglutide 2.4 milligrams once weekly versus placebo. So the patients that were enrolled in the study were adults that had known clinical diagnosis of heart failure with preserved ejection fraction and BMI, body mass index, of at least 30 kilograms per meter squared or higher. These patients had to have an ejection fraction of 45% or more. They had to have New York Heart Association functional class of at least 2 or higher, and a Kansas City cardiomyopathy questionnaire clinical summary score, which is a gold standard measure of assessing symptoms and physical limitations in heart failure, of less than 90. In addition to that, patients had to have at least one additional parameter, either documented elevated left ventricular filling pressures, elevated natriuretic peptides, plus structural echo abnormalities, or recent hospitalization for heart failure, in addition to ongoing diuretic requirement or structural echo abnormalities.
How long was administered the semaglutide?
So patients were randomized to semaglutide or placebo and treated for 52 weeks.
Okay, let's go to the results.
Sure. So we have two dual primary endpoints, the first of which was change in the KCCQ clinical summary score. Patients that were treated with semaglutide had a much greater improvement in KCQ clinical summary score. The treatment difference between semaglutide and placebo was almost 8 points in favor of semaglutide, with a highly significant p-value of less than 0.001. The second dual primary endpoint was change in body weight. We saw, not surprisingly, that patients treated with semaglutide had much greater degree of weight loss, with a treatment difference of about 10.7% in favor of semaglutide, also highly significant. In terms of secondary endpoints, we observed that semaglutide-treated patients had significantly greater improvement in 6-minute walking distance and significantly greater reduction in inflammation. And also, the safety looked really good in the trial as well. In fact, patients treated with semaglutide had about half the rate of serious adverse events as those treated with placebo. Finally, just a couple of points about exploratory endpoints. We saw a greater reduction in NT-proBNP in patients treated with semaglutide, and we also observed that they had fewer clinical events of heart failure hospitalizations and urgent visits, even though the number of those events was small, only 13 events, but only one of those events occurred in the semaglutide group and 12 in the placebo group.
How do you explain these very good results? Is only weight loss, or maybe there is something else?
Right. Well, the entire hypothesis behind the trial was that obesity is not just a coexisting condition, it's not just a comorbidity, it's in fact the root cause and a key driver of the development and progression of HFpEF. So when you target obesity, you actually can produce substantial benefits for patients with heart failure and preserved ejection fraction, and that's exactly what we observed. Now, the question of how much of it is weight loss and how much of it are other mechanisms is very difficult to tease out in the setting of a clinical trial, because many of these things are happening at the same time. With that acknowledged, I think weight loss is one of the key components of why patients benefit, but it's certainly not the only reason that we see the benefits that we observed. And again, the demonstration of that is very substantial reduction in inflammation, reductions in NT-proBNP indicating decongestion. So I think ultimately it's not one mechanism, it's multiple mechanisms of benefit, but weight loss is definitely a component of and a key contributor to what we're observing.
Very good. And when the drug will be approved for this indication, which do you think will be the better place in therapy? So which patient, in which condition, how to exploit this very good data?
Yeah, I mean, I think the patients that would benefit from it the most are the types of patients we included in the trial. Those patients that clearly have heart failure with preserved ejection fraction and have a BMI of 30 and above would be the most likely ones to actually experience similar improvements in their symptoms and physical limitations and quality of life that we observed in the trial.
As an add-on therapy to the existing drugs?
As an add-on therapy to whatever the usual or standard of care is, locally wherever the patient is being seen. And of course, the standard of care is evolving, as we saw at this conference with the new guidelines, but I think it would be on top of whatever the usual care is.